Oh, thank you. So thank you for the introduction, and I would like to thank first the organizing committee for giving me the opportunity to present our study that recently published and dealing with the detection of tumor margin during image-guided surgery. So this is the illustration on the cover that show the image-guided surgery, where the surgeon is equipped with special goggles that make it clear to define the borders of the tumor using smart or nanoprobes that marking it in real time during surgery. So why is it needed? Today, when cancer is diagnosed in its early stages, the standard of care is surgery. And upon complete removal of the tumor, the patient can be potentially cured from the cancer. So to ensure that, the surgeon are taking samples during the surgery for later on to be assessed by pathologists for cancer cells in the cutting edge of the tissue removed. When there are no cells, this is termed as negative margins. However, when cells are detected by the microscope with the assessment of the pathologist, it is termed as positive tumor margins and are sometimes associated with the recurrence of the disease and the requirement for the patient to undergo an additional surgery. So it is highly important to detect and to obtain negative tumor margins post-surgery. This is exemplified by several tumor types, for example, in lung cancer and colorectal cancer, 6 to 18% will have positive tumor margins, out of which 78% will have the recurrence of the disease. So surgeons taking additional 1 to 5 centimeters of functional and healthy tissue in addition to the tumor. In breast cancer, a third of the patient will have to undergo repeated surgery. And another important example is given by Mohs surgery that is done usually in skin cancer, where the histological assessment is done during surgery. And until no cancer cells are detected, the surgery is not over. So in order to guide the surgeon in real time inside the operating room during the surgery, image-guided surgery field recently emerged, and several examples are given by the clinically available agents that are non-targeted, like indocyanine green and methylene blue that are used for certain surgical procedures, and by 5-aminolevulinic acid that is FDA approved for the resection of brain tumors, glioma brain tumors. So there is still a high motivation to develop novel and more specific probes that will delineate the tumor boundaries in real time, but as opposed to low molecular weight agents that can be distributed to the tumor and as well to the healthy tissue, when introducing a polymeric backbone that can obtain high payload of imaging agents and can preferentially accumulate in the tumor due to the leaky vasculature and retain them longer due to the impaired lymphatic drainage, we can exploit both the EPR effect, and with the addition of turn-on ability, we can also gain its activation in the tumor site to generate a fluorescent signal that will glow over the dark background of the healthy tissue. And we can obtain this activation by certain enzymes or analytes that are overexpressed in the tumor tissue. So with these two features, we can obtain both prolonged imaging duration and higher tumor to background signal. So for the enzyme that will activate our probes during the image-guided surgery, we were focused on cysteine cathepsins, which are known to be overexpressed and highly activated in many tumor types. And we collaborated with Professor Galia Blum from the Hebrew University and used her activity-based probe, which composed of fluorescent tag cysteine cathepsin linker, and warhead that can covalently link to the active enzyme, and we could show the high activity of the cysteine cathepsins in several mammary and melanoma tumor tissue lysates. We focus on two main models of 41 mammary adenocarcinoma and 5B1 melanoma, and further imaged their location inside the tumor sections of mammary and melanoma, and showed higher, again, in comparison with the with the healthy tissue of mammary and skin. So next, with the help of Yana Epstein and Evgeny Pisarevsky, we designed and synthesized 3 novel polymeric probes, turn-on probes that are optically silent while traveling the body due to self-quenching or FRET interactions between densely packed dyes or quenchers, and can be activated to their turn-on state by either cleavage of suitable linker or degradation of a biodegradable polymeric backbone. And the question that we asked ourselves for these 3 different polymers or polymeric systems, how their size change and the different mechanism of activation can affect the enzymatic efficiency, the tumor to background signal, their pharmacokinetics, and what will be the suitable time for image-guided surgery for each one of them. And these are their molecular structure. The linker-based system is composed of HPMA copolymer, and for the cysteine cathepsin biodegradable polymer, we chose the polyglutamic acid PGA polymeric backbone and covalently linked Cy5 near-IR molecules or a quencher, dye quencher, dark quencher. We characterized their size and morphology using electron microscopy and DLS measurements, and found their size to be around 7 nanometers, which is currently suitable with currently available imaging agents in clinical trials. And for the biodegradable polymeric system, the size was above 100 nanometer, which can exploit the EPR effect beneficially. We saw that upon higher payload of same dye or with quencher, we got a higher quenching efficacy with a reduction of the fluorescent signal up to 70 or 80% in comparison with the free dye alone. And another important stuff is, in addition to reducing the fluorescent signal and quenching efficacy and increasing the quenching efficacy, is to enable the turn-on ability. So upon incubation with the cathepsin B, which is a member of the cysteine cathepsins, we saw the elevation in fluorescent signal, while in the absence of the enzyme, the elevation was negligible, and it was clearly demonstrated by imaging instrument and also by HPLC characterization, which showed the degradation of free dye by this peak from the polymeric backbone that is indicated by this broad peak. We found to have a beneficial enzymatic efficiency for the linker-based system. And lastly, after the characterization by HPLC from the tube, we moved forward to living cells. We saw the co-localization of our probes marked here in red with the lysosomes marked here in green, which are the main compartment of the cells that overexpress cysteine cathepsins. And later on, we showed it with higher spatial resolution by using the confocal imaging, and showed the turn-on ability by endogenous cathepsins inside the living cells by the elevation of fluorescent signal indicated by the histogram that shifted to the right, in comparison with the free dye or addition of cysteine cathepsins inhibitor. And lastly, before moving to in vivo studies, we showed the stability of our probe in different media, and that it was non-toxic towards hemolysis of red blood cells in the concentration used for in vitro and in vivo. So then we moved forward for in vivo study. We imaged our probe tumor to background ratio upon intravenous administration. And we found the highest tumor to background ratio here in gray, 4 hours post-IV injection. And in order to show the importance of additional turn-on ability, except from exploiting the EPR effect, we used a control probe that is always on because they possessing a non-cleavable glitine-glitine linker. And we showed that during 4 hours post-IV injection, the tumor to background ratio was not elevating. So we proceeded with our turn-on polymeric system and revealed by pharmacokinetic studies a half-life of 19 minutes and the clearance from the plasma almost completely after 3 hours. So we started the image-guided surgery accordingly 4 hours post-IV injection. And indeed, we could clearly see the tumor before surgery, detect its boundary during the whole surgical procedure until it completely removed, which was indicated by the background fluorescence signal. We could see the tumor glowing and our probe in the section in the areas of the tumor that was highly fluorescent in comparison with healthy mammary that barely shown the fluorescent signal of our probe. In addition, the control groups that underwent standard surgery under white light only showed higher recurrence rates with tumor recurrence and metastasis burden, and which was also detected by our turn-on probes with clear threshold between the healthy tissue and the cancerous tissue. And in addition, they were the control group survived for less time. We could also detect metastasis in the brain area. And finally, important comparison that we did was to evaluate the tumor to background ratio of our probe against FDA-approved 5-aminolevulinic acid and ProSense, which is polymeric system commercially available. And we were happy to find that the tumor to background ratio was higher for our system, and also the mice treated with our turn-on polymeric probe survived for longer time. So just to conclude, the polymeric systems bear several beneficial properties, such as exploiting the EPR effect, the turn-on ability that could be detected also inside the lysosome of cancer cells, possess prolonged retention inside the tumors in comparison with free and low molecular weight imaging agents, which enables the precise detection of the tumor margin during long surgical procedures, and finally, and most importantly, to improve the survival of the treated mice. So I want to thank my group, my supervisor, Professor Ronit Sachi-Fainaro, and to thank you for listening. And do you have a question?
Thank you, Rachel. Any questions?
Okay, so this is a very nice talk. Nathan earlier in the plenary suggested that since tumors in people are not like in mice, and it's not only what he said, but others suspect that, excuse me for being blunt, that EPR in humans is bullshit. That's why for 30 years, nanomedicines didn't cure people. So the question is, neither if you agree or disagree with such claims, but can you make these polymer-based molecules sufficiently small to go out through normal fenestrations?
Yes. Thank you for the question. It's a very important question. The EPR effect is arguably in the field, is it exist or not. There are tumor models also in mice that we don't see the EPR effect. In this model, it was really vascularized model with a lot of, so we could see it very nice in the mice. We could see it nicely in the mice. Regarding your question, if we can make it small enough, the question is what is small enough? Because I showed you the physical-chemical characterization of the size and indicating, where is it? Indicating that one of the, we generated 3 systems, and one of the systems was quite small, around 7 nanometers. This system. It was quite small. So 7 nanometers.
I think we need to be 2 nanometers to go out of it.
Yes. Although 7 nanometers sized particles are currently evaluated in clinical trials. And many trials, and this trial, specific trial that I'm talking about, claim it's potentially better and the ideal size to both accumulate in the tumor, not only because the EPR effect, and also to be able to extravase, to clear it from it. But we can also generate system with 4 nanometer size polymers with 4 nanometer size and check how they will be function as imaging probes that are not that tiny, like low molecular weight of 600 daltons, but that suffer from fast clearance and do not enable you to do prolong the imaging procedures. But we can do it. We can, to do smaller systems, it's actually easier for us. The harder task is to make them longer and retain the polydispersity. But for smaller systems, it's actually easier for us, and then we can do it. For this specific work, we compared between 7 nanometers to above 100. And we did it in mice model, and very nice with EPR effect. But yes, it's a very important question, and yeah, we should address this.
Well, Rachel, it's a very interesting talk, and I'm sure there will be more discussion over the poster session. We have to continue, so thank you again, Rachel, for the presentation.